Good morning. This is probably the most relaxed I've felt prior to a talk in my whole life, so that's great. Thank you so much. Thank you for being here, and for those attending virtually or missing out, what a beautiful location for a conference. So today I'm going to talk about 3 different abstracts that were presented at ASCO this year in the colorectal space. And even if you didn't attend ASCO, you've probably heard about all of these because they were very well discussed and publicized even in the lay press for good reason. So, and 2 of them actually had concomitant New England Journal manuscripts as a result. So we're going to talk about Paradigm, which is the phase 3 study in Japan of FOLFOX plus either panitumumab or Avastin, bevacizumab, in the first line in patients with RAS wild-type metastatic colon cancer. Then we'll talk about Dynamic, which is looking at the use of circulating tumor DNA in stage 2 colon cancer to try to guide adjuvant chemotherapy. That's the randomized Dynamic trial. And then finally, the single agent PD-1 blockade for MSCI locally advanced rectal cancer patients. All right, so we'll start with Paradigm. So this was presented in the plenary by Dr. Yoshino, and this was a prospective phase 3 study really looking at the question of which biologic do we use in the first line in combination with a cytotoxic chemotherapy backbone. So these were patients who had RAS wild-type disease. So prior studies had actually looked at that in post-hoc analyses, but this was prospective. And patients were previously untreated. There were 823 patients randomized to either FOLFOX plus panitumumab or FOLFOX plus bevacizumab. And the endpoints changed over time as we learned more. The study started in 2015, I believe. So as we learned more about the importance of primary tumor-sidedness, that did affect this study. But ultimately, the primary endpoint was median overall survival in the left-sided population, and it was powered such that if that was a significant finding, then overall survival could be looked at in the overall population. I'll note here that the stratification factors, there were several, but primary tumor-sidedness was not one of them. So who are these patients that were enrolled in this study? I'll just point out a couple of things. Number one, the majority were male, actually, and this was in Japan. Patients had very good performance status, typically, and there were about 20% of patients who had right-sided disease. So we will look at that in terms of one of the exploratory endpoints. So the primary endpoint, however, was overall survival in the left-sided population. And you'll see that even though the curves are very close and even cross at times early on, ultimately, as time went on, the curves started to separate in favor of the panitumumab-containing regimen. And in fact, there was about a 3.5-month overall survival advantage to patients treated with panitumumab in the first line, and this was statistically significant. The overall survival in the overall population was then looked at because, again, the left-sided was statistically significant, and we saw that, again, early on the curves were almost identical and in fact crossed, but then did favor the panitumumab-containing arm in the long run. And this was about a 5-month difference in overall survival. So interestingly, progression-free survival, which was a secondary endpoint, was not different in either the left-sided population or the overall population. And there are several hypotheses for this, including, as I'll show you, the panitumumab-containing arm typically had a deeper responses. It's not because some of the patients did ultimately go on to surgery, because those, even though there were more that went on to surgery, they were censored at that time. So that wouldn't have accounted for that. And I'll show you one other small fact that may lead to some of the difference in overall survival as well. So in addition to overall survival, there were differences favoring panitumumab, such as response rate of 80.2% versus 68.6% in the bevacizumab-containing arm in the left-sided population. Disease control rate overall was extremely good in both groups, and I think that goes to show that our first-line therapies are typically very active. And the median duration of response was about 13 months versus 11.2 months. And I think when we think about that, I mean, we know that patients are typically on the first-line therapy for the longest time period. So I think what that also tells us is we need to be really cognizant of toxicity, as I'll come back to in just a second. And then, as I mentioned earlier, there were more patients who did have an R0 resection in the panitumumab-containing arm. So here's the depth of response data, and where you can see that the median change in tumor, in measurable tumor, was about 60% in panitumumab plus FOLFOX versus about 43% in the Bev-containing arm, and that was in the left-sided population. So here we see the toxicity, which is perhaps not surprising. We know that panitumumab typically does have more toxicity than bevacizumab, and certainly the toxicity profiles are different, and no new safety signals are seen here. But what I want to call your attention to is really that not only are there slightly increase in greater toxicities, but the toxicities that patients live with every day that we don't typically make dose adjustments for, especially grade 1 and 2, are significantly higher in many of these aspects, including the acneiform rash, some of the GI toxicities, hypomagnesemia, all the things that we typically do attribute to panitumumab. And then one other thing that I thought was really interesting in this presentation was looking at the subsequent treatments that patients received after first-line therapy. So interestingly, of the patients, you can look in the left-sided columns, the patients who received panitumumab in the first line were randomized to that. About a third wound up ultimately receiving that in a later line of therapy. So whether that was it was stopped early for toxicity, but they hadn't progressed and they got it later, or perhaps this may speak to the anti-EGFR rechallenge. This may also have something to do with the overall survival benefit as well. And interestingly, the patients who were randomized to the bevacizumab-containing arm, initially, only 55% ultimately received an EGFR inhibitor, so I thought that that was an interesting point as well. As one of the exploratory endpoints, they looked at overall survival in the right-sided population. Again, this was about 20 to 25% of the overall study population. And even though this was not statistically significant in terms of a difference, numerically this did favor the bevacizumab-containing arm. So I think that's important reinforcement of our practice that really we shouldn't be doing anti-EGFR in the first line for patients with right-sided tumors. And so my conclusions from Paradigm, I thought this was an excellent presentation. I think FOLFOX panitumumab is a very good first-line option for patients with left-sided RAS wild-type disease. I don't think it's the only option, and it's nice to know that we have prospective phase 3 data for this, but because of toxicity, I don't necessarily treat all of my patients with this regimen. I do also want to comment that we didn't specifically mention this, but this is for patients who are microsatellite stable and BRAF wild type. So the patients who are MSI high or BRAF mutant might benefit from other therapies such as immunotherapy or non-anti-EGFR containing regimens in the first line. We talked about the PFS being similar between arms, response rates, R0 resection rates, depth of response, all better in the panitumumab arm, and unfortunately toxicity, as you might expect, being worse. We know now or have additional data that bevacizumab is a better biologic in the first line for patients with right-sided disease. And I think these data overall just highlight that early molecular profiling is really critical. We used to use it in later lines of therapy, and we didn't need it right up front. And now for a multitude of reasons, for MSI, for RAS, all of these things, we really need NGS in as soon as patients are diagnosed. And ultimately, how I use these data are I talk to patients about not only survival and efficacy outcomes, but also toxicity, and let them guide me in terms of what side effect profiles are more reasonable to them and their goals and preferences. So next we're going to move to Dynamic, which was a study presented by Dr. T from Australia. And this is a really interesting study that I think flew under the radar a little bit because it was presented during the GI poster session. So many of us were not at the presentation, unfortunately, but ultimately were able to review this data later. So this was a study that patients with resected stage 2 colon cancer were randomized. One key factor was that they had to have adequate tumor tissue from the resection within 4 weeks postoperatively for this study, and I'll explain why that's important. But they were randomized in a 2-to-1 fashion to either ctDNA-guided management or standard management. So they had blood collection at 2 time points, at week 4 and week 7 post-op. And then if they were randomized to the ctDNA guided management, if they were positive by that assay, they went on to receive adjuvant chemo. However, if they were negative at both of those time points, they were observed. As opposed to what we standardly do is try to decide based on the clinical factors that we know, the pathology factors that we know, and try to make our best decision as investigators or treating physicians as to what might be best for the patient. The 2 endpoints that were discussed at ASCO were recurrence-free survival rate at 2 years, and interestingly, the proportion of patients receiving adjuvant chemotherapy. So in this study, they used a tumor-informed approach, which when we're thinking about ctDNA, there's tumor uninformed and tumor informed. So what is tumor informed? This is basically a customized assay where the patient's own resected tumor tissue is utilized to identify mutations that are found in that particular tumor. So in this case, there were 15 genes that were looked at that were the most commonly affected in colorectal cancer. And then those mutations were looked for in the patient's individual plasma at those 2 post-op time points to see if the ctDNA was deemed positive or negative. So who are these patients who are on the dynamic study? I'll note that about 85% in both groups were T3. About 20% in each group were MSI high, so this is kind of an interesting study population. And about 40% in each group were considered by the investigators or the treating physicians to be clinically in a high-risk group. What does that mean? Have to be microsatellite stable and at least one of the high-risk features that we standardly look at when we're thinking about whether adjuvant chemotherapy would be helpful or not. So in this slide, we actually see one of those key secondary endpoints, which was the proportion of patients who received adjuvant chemotherapy. And what you'll notice here is that by the ctDNA guidance, actually only about half of the typically offered chemotherapy patients actually received chemotherapy. So again, the ctDNA guided patients, only if they were positive did they receive chemotherapy. So if they were negative, they were observed. But the standard management really had flexibility. The other thing that I thought was interesting here was that, and this makes sense when you think about it, but in the standard management arm, almost everyone received single agent fluoropyrimidine, whereas the ctDNA guided patients, again, those were the positive ctDNA, they had the option, the treating physicians had the option, but most of them did receive oxaliplatin-based doublet therapy, which makes sense. You may be a little bit more nervous if you know they have circulating tumor DNA in the bloodstream. And finally, on this slide, I think what's important to note is that the time from surgery to the start of chemotherapy was significantly longer in the ctDNA guided group. And that makes sense. You have to develop this tumor-informed assay. That takes time. You really need to identify these patients early, so it takes a lot of coordination with the surgeon. But it was the difference between about 7.5 weeks and almost 12 weeks. So the primary endpoint here was recurrence-free survival at 2 years. And what you'll see, and this was actually powered as a non-inferiority study. So what they were looking to see is that randomizing patients to the ctDNA guided management, even though they were only half of them compared to the standard management received chemotherapy proportionally, their recurrence-free survival was not inferior. So I think that's really important to see, looking at that 2-year time point, 93.5 versus 92.4%. It's not long enough yet, clearly, but we will get the data over time. But that's an early first milestone that's important. What about if you look at the ctDNA guided management group and separate them between the negative and positive patients? How did they do over time? And again, we see that the patients who are negative, who were observed, did very well, even at the 3-year and beyond time period. However, the patients who were ctDNA positive, they all did receive chemotherapy, and still their survival, their recurrence-free survival at 2 and 3 years was less, as you might expect, but this was not statistically significant because of the numbers. So what about looking at the combination of ctDNA and other clinical factors like clinical risk and T-stage? In the figure on the left, you'll see that in the blue line, those were patients who were ctDNA negative and considered low risk by their physician. The middle line, or really the yellow line, was ctDNA negative and high risk. So those patients did a bit worse. And then ctDNA positive that were treated with chemotherapy. In the same kind of analysis, they looked at the impact of T stage. So T3 and T4 patients were enrolled on this study. And so even though many of them were T3, based on what I showed you, there was a subset of T4 patients. And you can see here that yellow line, which is ctDNA negative but T4, actually did worse than the patients who were ctDNA positive and received chemotherapy. So what are the conclusions that I took away from Dynamic? Well, we definitely saw that utilizing the ctDNA-guided approach reduced the number of patients getting chemotherapy, and the 2-year recurrence-free survival was non-inferior to how we standardly assess chemotherapy need. I don't think that this is across the board ready for prime time, though we're slowly inching our way there for sure. There are still many unanswered questions. I think we can safely say that patients with positive ctDNA after surgery may benefit from adjuvant chemotherapy, though how much is still yet to be determined. And I think this did give us more data that patients who have ctDNA negativity, at least at those 2 time points after surgery, do pretty well without adjuvant chemotherapy. The big takeaway from my standpoint is that we need to continue to enroll on prospective clinical trials. So there are several across the country now that are pretty widely available and even recently opened, like COBRA and Circulate. COBRA is looking at patients who are T3 and 0, who you would normally do surveillance for. And then Circulate is for stage 2 and 3, and it looks at intensifying versus de-intensifying chemotherapy based on ctDNA positivity. And then the Stand Up to Cancer Act 3 trial run by Dr. Parikh is looking at another really interesting point is what do you do if after you give adjuvant chemotherapy, the ctDNA is still positive? So we have a lot of questions to answer, but it is an exciting time, and hopefully this will be able to transform how we treat patients. And finally, what probably everyone has heard a lot about, not only from ASCO, from the lay press, from your patients and their loved ones, is this study of dostarlimab in MSI-high locally advanced rectal cancer as presented by Dr. Sursik. This was a single institution. It's an ongoing study, but she presented on the first 14 evaluable patients, which we'll talk about. These patients had stage 2 or 3 MSI-high locally advanced rectal cancer, and they were treated upfront with dostarlimab, PD-1 blocker, every 3 weeks for 6 months. If at that time they had radiographic and endoscopic clinical complete response, they went on to non-operative management and surveillance. And if they had residual disease at that time point, they went on to standard chemoradiation and ultimately surgery. So the objectives here were really to look at response rate of PD-1 blockade with or without chemo and radiation, and the path CR and clinical complete response rate at 12 months after PD-1 blockade. But as you'll see, some of these objectives have changed a little bit. So the demographics for this study, as you might expect, so MSI-high tumors tend to be bulky, tend to be locally advanced, locally invasive. So 78% did have T3 or T4 disease, and almost all of the patients were node positive. What I'll turn your attention to is near the bottom, however, only about 60% of patients had germline MMR mutations. However, 100% of patients were BRAF wild type. So we typically think one of the markers of a sporadic tumor is BRAF mutation in the V600E gene, but really, we saw kind of an interesting mix there. However, this was the takeaway from the study is that there were, in the first 14 evaluable patients, there was an overall 100% clinical complete response. So that means both radiographically and endoscopically. However, I'll point you to the follow-up column. There are a few patients approaching now 2 years post-dostarlimab therapy who still remain free of disease. But most of the patients are still very early in follow-up. So we need to be cautious and wait for that data to mature. Here's the swimmer's plot looking at not only duration of response, short median follow-up of 6.8 months thus far. This did include the last 4 patients who are not quite evaluable because they haven't had 6 months of therapy. But you'll see that a couple of patients actually achieved the clinical complete response even before the 6 months of therapy were up. So what are my conclusions from this late-breaking abstract? I think it goes to show us that it is now imperative to test for mismatch repair deficiency or microsatellite instability in patients with locally advanced rectal cancer. We used to do that, but we didn't feel so strongly that we needed it before making treatment decisions. And now I feel like we really need that information. But this is true for all stages of colorectal cancer now. And we're learning to use that information earlier and earlier in our treatments. The study did induce a clinical complete response with neoadjuvant immunotherapy alone in all 14 patients. This was a carefully selected population. Rectal cancer patients who are MSI high are probably less than 5% of the patients that we see, but still a very important subset. We're not sure yet about generalizability. Again, no patients had BRAF mutations, and the majority did have germline mismatch repair mutations, so Lynch syndrome. And the 2 biggest questions in my mind are, how much immunotherapy is enough? I mean, everybody got 6 months, but probably you may not necessarily need that. But the biggest question is really, what's going to happen long-term to these patients? I'm hopeful that this really is a cure, but we don't know that yet. So we need longer follow-up and more testing before this truly becomes standard of care. This study at Memorial is still ongoing, and for those who can't or are not able to travel to New York, we actually I'm running an ECOG study, 2201, which is looking at nivolumab and ipilimumab in the same population of patients, and it's open in 70 sites across the US, so hopefully somewhere near you if you don't have that one open. And we really need to complete those studies to see the generalizability of this therapy and what happens to patients long term, and hopefully this is paradigm shifting. And with that, I will finish, and I'm happy to answer any questions either now or later. So thank you so much for your attention.